This second set of practice problems is focused on content covered since the first quiz to help you prepare for quiz 2. I'm going to read each question and then I'll put up the little pause icon so you can stop the video and answer the question on your own and then continue on at your own pace. Use direct age adjustment using the total of the two populations as the standard population to calculate the age-adjusted cancer mortality rates for gold miners and the general population. Round your final answer to the nearest whole number. Remember that direct age adjustment is one of the techniques we talked about for standardizing the rates from two different populations to a common age structure. This allows you to make a comparison between the two populations. For direct age adjustment, you need to know the age-specific rates of both populations. First, we're going to create our standard population by adding the people in the population in each age group together to make our standard population. So we add the gold miners who are age 0 to 30 to the people in the general population from that age group to get our standard population for the 0 to 30 age group. We add gold miners who are 31 to 60 to people in the general population who are 31 to 60 to get our standard population of 31 to 60-year-olds, and do the same for our 61 and over population. And we add those up to get our total standard population. Next, we use the cancer mortality rate from the gold miners and multiply the rate for each age group by our standard population we just created. For the 31 to 60-year-olds, we multiply 20 by 50,000, then divide by 100,000 to get 10. For the 61 and over age group, we multiply 200 by 31,550, then divide by 100,000 to get 63.1. Then we use the cancer mortality rate from the general population and apply it to the standard population. So we multiply 3.3 by our 0 to 30-year-olds to get 1, and multiply 5 by our 50,000 31 to 60-year-olds to get 2.5. And we add them to find the total expected deaths in our standard population. So our age-adjusted rate for the gold miners is 73.1 divided by our total standard population to get 65. And using the general population rate, we divide 10.9 by 112,500 to get 10. It's important to remember that these are fictitious rates because the standard population doesn't actually exist anywhere. We come up with these rates in order to make a comparison between the two populations that isn't skewed by age differences in the two populations. Which of the following is an accurate interpretation of the adjusted cancer mortality rates from the previous slide? Cancer mortality in gold miners was higher than what was expected compared to the general population. We're comparing the rate of 65 to the rate of 10. So more gold miners are dying of cancer than what would be expected if they were members of the general population. The Arctic is warming 4 times faster than the rest of the planet. Traditional underground meat storage methods that have been used for centuries are being impacted by climate change. As the permafrost warms and cellars are exposed to extreme weather events such as flooding, microbial hazards including botulism and physical hazards including cellar collapse present public health hazards. A team conducts a cross-sectional survey to determine how many families in rural Alaska are still relying on traditional cold storage for meat in 2024. This data will help quantify the magnitude of the risk and will be included in grant applications if designing an intervention to upgrade rural families to food storage methods that will remain safe with the warming climate. Is this surveillance? No, this wouldn't be classified as surveillance because surveillance has to be an ongoing, regularly occurring activity, not a one-time project. Your grant to improve access to climate-resilient food storage methods gets funded. Your intervention involves meeting with families in their homes for in-depth discussions about food storage and providing information on how to prevent foodborne illness and injury. How would ethics factor into what incentive you should offer study participants to compensate for their time and for welcoming you into their home? If your grant includes funding to ship a free meat freezer to each household, would this be ethical? Probably not. Institutional review boards overseeing research are ultimately responsible for meeting the requirements of Title 45, Part 46 of the Code of Federal Regulations, but the researchers also have an obligation to make sure any incentives for participants don't cause undue influence that might compromise a person's ability to provide informed consent. Something like a freezer for a household has so much monetary value that people might feel like they have to participate in this research study so they don't miss out on the freezer. So that would be too large of an incentive. The health department is conducting a longitudinal cohort study using primarily qualitative data to understand the lived experience of Alaska Native people with long COVID. The research team is conducting interviews every 6 months to gain a deeper understanding of what it's like to live with long COVID within the cultural and social structure of the local community. Because the focus is on a particular tribe and local culture, the researchers don't plan to attempt to generalize their findings to other communities. The goal is to improve the quality of services provided to people with long COVID who access care from the tribal health organization and identify other social services that may improve quality of life for this group of individuals. The Tribal Council and Tribal Health Organization will meet every 6 months for the first 3 years and annually thereafter to discuss the results from each round of data collection and use the data to inform local program planning to serve the study participants. Is this research? This probably would not be considered research because the primary objective is not to create generalizable knowledge. Blank surveillance involves public health agency staff periodically gathering data from sources such as hospitals and laboratories, while blank surveillance relies on healthcare providers to report cases on their own initiative. In active surveillance, the public health agency initiates collection of data from labs, healthcare providers, or the public, such as by making phone calls or going to hospitals and doing chart reviews. While in passive surveillance, data is generated without solicitation by a public health agency, such as continuous reporting of certain notifiable infectious diseases to health departments at the time of diagnosis by clinicians. Passive surveillance systems will miss cases. This is an expected downside because you're not paying the clinicians or members of the public to report cases and they have other things going on. But passive surveillance systems are much more cost effective. It takes a lot to have an active surveillance system where you often have a team of epidemiologists, including doctors, nurses, statisticians, and data management professionals all working together to be totally sure that no cases of that condition are missed. Public health agencies have to decide based on the specific condition whether an active surveillance system is warranted or whether a passive surveillance system will get the job done. Based on the data provided, what was the all-cause mortality rate for females aged 35 to 55? Annual mortality rate is the deaths in a year divided by the mid-year population times 100,000. We divide the 236 females aged 35 to 55 who died in 2020 by the mid-year population of females in that age group and multiply by 100,000 to get 31 per 100,000. What was the case fatality rate of COVID-19 for males over age 55 in 2020? Case fatality rate is actually a proportion. It's the number of individuals dying during a specified period of time following diagnosis or disease onset divided by the number of individuals with the specified disease multiplied by 100%. 120 men over age 55 died of COVID-19 in 2020, divided by the 700 cases of COVID-19 in that age group in men, multiplied by 100 is 17%. What was the proportionate mortality of COVID-19 for males aged 20 to 24 in 2020? Proportionate mortality tells us what percent of deaths were due to a specific cause. Proportionate mortality is a proportion. It's the number of deaths due to the specified cause divided by the total number of deaths. We divide the 25 men aged 20 to 34 who died of COVID-19 in 2020 by the 75 men in that age group who died in 2020 and multiply by 100 to get 34%. You're interested in using U.S. cancer surveillance data from the Surveillance Epidemiology and End Results (SEER) program available from NIH's National Cancer Institute for our project. What is the purpose of age-standardized rates in cancer surveillance data? Age-standardized rates adjust for differences in cancer detection methods between regions. Age-standardized rates account for variations in population age distributions to allow fair comparison of cancer incidence across different populations. Age-standardized rates are used to measure the absolute number of cancer cases in a given year, or age-standardized rates reflect the impact of changes in cancer treatment effectiveness over time. Age-standardized rates are used to make comparisons between populations whose age structure has changed over time, or to make comparisons between two populations with different age structures. When talking about population pyramids, I use the example of the United States compared to Uganda, which are two countries with very different age structures. So you can't make a direct comparison between the two populations. Because the incidence of most cancer increases with age, an older population would likely have a higher incidence of most cancers, so you need to use age-standardized rates in order to make comparisons between populations with different age structures, because comparing the crude cancer rates would be misleading.